Hi, everyone. Welcome. Thank you for joining us for part one of our webinar series on the Women's Health Needs Study. My name is Caitlin LeMay. I'm the director of the US End FGMC Network. The US End FGMC Network is a vibrant and collaborative group of over 200 survivors and activists working on ending FGMC in the US and globally. I'm thrilled to be joined today by Petri Ubri from NORC at the University of Chicago, who will be sharing some of the findings of the Women's Health Needs Study. Just as a reminder, this is part one of a webinar series, and part two will be next week on Thursday, June 15th at 1 p.m. Eastern Time. And part two will include a panel discussion from community partners Amani Women's Center and Sauti Yetu Center for African Women, where they will be sharing how they are using the findings from the study to inform their organizations and communities, programs, services, and needs. Just to let you know, we have dedicated time at the end of this presentation for a Q&A, so please submit your questions throughout the presentation and we will do our best to get to them at the end. You can find the Q&A button along the bottom of your Zoom icon bar. Without further ado, I'm so excited to introduce you to Petri Ubri. Petri served as implementation lead on the Women's Health Needs Study, where she worked with community partners on the design and implementation of data collection activities. Petri has over a decade of experience leading and conducting qualitative and mixed methods research. Her work focuses on health equity, social drivers of health, and Medicaid policy. She has extensive experience using participatory and culturally responsive principles and practices to work with underrepresented communities in research and evaluation. So thank you so much for joining us, Petri, and I will hand it over to you.
Thank you. And thank you everyone for joining us today. As Caitlin noted, my name is Petri, and I will be giving you some background on the study. So just to start, we wanted to start with a background on how the study came about before we get into some findings. So female genital mutilation and cutting, FGMC, also known as female circumcision, is a health and human rights concern that can have both short and long-term negative health consequences for girls and women. And so information about US women from countries where FGMC is practiced and prevalent is limited. So there are various studies out there, but they tend to have smaller sample sizes or focus on specific populations or specific countries of origin from a limited selection of countries, or reside in a single US metropolitan area. So the Women's Health Needs Study was designed to fill that gap in our understanding about FGMC among US women. WHNS was a one-time study that collected information on women's healthcare experiences and needs, as well as on FGMC. So the purpose of WHNS was to identify and document the health needs and experiences of women in selected US communities who are potentially affected by FGMC. We wanted to learn more about their experiences and attitudes related to FGMC, their FGMC-associated health conditions, and we also wanted to learn about their access to healthcare services, reproductive health characteristics, including things like contraceptive use, childbearing, and use of preventive care. These findings will inform prevention efforts and public health strategies to meet those identified needs, both at the community level and then at national level, as well as we talk about acknowledgements at the end of the study. I wanted to acknowledge our subject matter experts and community partners that were critical to design and implementation of this study. So we worked closely with study communities on the study design, developing culturally sensitive approaches to outreach and data collection, adjusting study approaches for compliance and social distancing, particularly because data collection happened in the height of the COVID-19 pandemic, developing community study venues and outreach approaches, and guidance on study materials and study staff recruitment and training. So we definitely worked with our site partners on having community interviewers, on data collection approach, on design, and all of those things. And so hopefully you will be able to join us next week and hear more directly from our community partners about that experience. In addition, we convened a working group of national experts that advised on methods and materials. A little bit about the design of the study. The study took place from November 2020 to June 2021 in 4 metropolitan areas in the United States: Atlanta, Minneapolis, New York, and Washington, D.C. Selection of these sites were based on communities that had large concentrations of residents from countries where FGMC is widely practiced. So we were looking for communities that had large concentrations of women from the countries that we'll talk about in the next few slides that were part of this study. We used a non-probability sampling combined with venue-based sampling and respondent-driven sampling approach. What this means is it's not kind of random or a naturally representative sample. We were working very explicitly with community partners to be able to reach women who could be affected by FGMC in these specific 4 areas. We had venue-based sampling, which relied on where women tended to congregate in specific areas within those communities and organizations within those communities to be able to identify them. And then respondent-driven sampling, which means that women who participated in our study were asked to refer other women from their networks to the study as well. So this was cross-sectional. We had a standardized screener and questionnaire that was administered by telephone, where we had community interviewers that were administering that questionnaire to the women who were participating in the study. Eligibility for the study included women aged 18 to 49. It required women to be born in or for their mothers to have been born in a country where FGMC is widely practiced. And we'll talk about our distribution of countries of origin in a few slides. And they needed to be able to speak one of the 7 study languages. So based on the populations and the countries of origin and conversations with our community partners, we identified the following languages in addition to English, which were Amharic, Arabic, French, Oromo, Somali, and Tigrinya. So the studies were available both in English and all of these languages, and our interviewers spoke at least English in one of these languages as well. Some things that we asked about in the questionnaire, there was just the screener just to make sure the women were eligible for the study. We asked about background characteristics just to understand their languages spoken, time since immigration to the United States, age at immigration to the United States, understanding household composition and marriage, including their marital status and age at first marriage or cohabitation. Community activities and networks, including if they worked outside the home, if they had membership in a club, association, or religious organization. Their health status and experiences with healthcare and provider, including just generally their health status, their health coverage, their access to healthcare services and barriers to care, and the availability and use of language interpretation within their healthcare settings. We also asked about women's health needs, including contraceptive use, timing of most recent pelvic exam, and age at first sexual intercourse, birth outcomes related to live birth history, prenatal care, and type of delivery, and FGM experiences, including FGM status and type, age at FGMC, communication with a health provider about their FGMC and their experience of health problems and their association, to the extent to which they associated it with FGMC, as well as whether the respondents' family practiced FGMC. Their attitudes and beliefs about FGMC related to the continuance of the practice, their changes in attitudes before or after immigration to the United States, beliefs about whether FGMC is required by religion and whether it can cause health problems, and their husband or partner's attitude about continuance of FGMC. We also asked about education and highest level of education completed. So here are some findings about the study so far. As I'll note in the previous slide, we had a lot of questions. So these findings don't cover every single question that we asked in the slide, but we just wanted to highlight some of the most prevalent or salient findings so far. We had over 1,000 women participate in the study. So 1,132 women participated. You can see in the chart the distribution by age and by level of education. The majority of women that participated, 69%, were aged 30 to 49. And the majority of women had some college education or higher. So 63% had at least some college education. And I'll pause for a second after every slide so folks have a chance to see the graph as well. In terms of immigration, generation, and marital status, most women that participated in the study had immigrated to the US at age 13 or older, which is what we call 1.0 generation, or the first generation. So you can see 87%. We also had 10% that were 1.5 generation, meaning that they immigrated to the US before age 13, and then 3% of women that were born in the US. The majority of women, 61%, were married or living with a partner. You can see there 14% had previously been married and 25% had never been married or had lived with their partner. In terms of country of origin, about 1/3 of women were from a country in West Africa, and this included various countries: Burkina Faso, the Gambia, Guinea, Mali, Mauritania, and Sierra Leone. And we'll note that the grouping of the West African countries together, as opposed to kind of separation with the others, were really based on the data sources, and we were using the American Community Survey to weight the sample, and the American Community Survey data did not separate out some of these West African countries, so we had to combine them in our analysis as well. 31% of women were from Ethiopia, and you can see the rest there: 13% from Somalia, 11% from Egypt, and 3% from Sudan and Eritrea. Some information about health insurance and interpretation preferences. Over half of women in the study had Medicaid coverage. Nearly 1/3 had private coverage, whether that was through their employer or coverage that they purchased on their own. And 17% did not have any health insurance. We asked women about their preference for having an interpreter when visiting a healthcare provider. 27% of women who participated in the study noted that they prefer having an interpreter when visiting their healthcare provider. Among these 20% of women who prefer an interpreter, 2 in 3 were offered one during the last visit, meaning that 1/3 of women who preferred an interpreter were not offered one during their last visit. Some information related to reproductive health. We found that over 3/4 of women that participated in the survey reported having received a pelvic exam or pap smear within the last 3 years. We saw that 17% had never had an exam, and 6% had had one over 4 or more years ago. We also found that over half of women surveyed reported having ever used birth control. And among women who had reported having ever used a contraceptive, 29% noted that they had used one in the last 30 days. Nearly 1/3 of women reported having delivered a child via C-section. And 18% of women who reported ever having sexual intercourse noted that they were under 18 at the age of first sexual intercourse. The majority of 59% reported being ages 18 to 24, and nearly 1/4 were 25 or older. Some findings related to experience with FGMC. Of the over 1,000 women that participated in our study, over half of them, or 55% of them, reported that they had experienced FGMC. And so we were kind of basing this on the definition from the World Health Organization that defines FGMC as all procedures involving partial or total removal of the external female genitalia or other injury to the female genital organs, whether for cultural, religious, or other non-therapeutic reasons. In terms of experience by country of origin, nearly 3/4 of our participants that were from Somalia reported having experienced FGMC. 59% of women who were from West African countries reported having experienced FGMC. 55% of those from Eritrea, over half of those from Sudan, 45% of those from Ethiopia, and 34% of women from Egypt reported having experienced FGMC. We found that older women reported higher rates of FGMC than younger women. So you can see here that women ages 18 to 24, 1 in 4 of them, or about 1/4 of them, reported having experienced FGMC, as compared to the older women in our study who were ages 40 to 49, nearly 3 in 4, or 69% of them, reported having experienced FGMC. We found that the majority of women who reported having experienced that FGMC noted that they experienced it before age 9. So you'll see here a breakdown by age. 12% of women reported they were too young to remember, so they didn't know the exact age. But 21% were less than 5 years old. 44% were 5 to 9 years old. 16% were 10 to 14 years old. 4% were over 15 years old. And 3% reported they did not know or did not remember at what age they had experienced their FGMC. Over half of women who reported experiencing FGMC reported that they had flesh removed from their genital area. And so I'll note that women could have selected multiple things. So this is, we categorize this based on the different categories. So sewn, if you had selected sewn clothes, you're kind of only in that category. And so 29% of women said their genital area was sewn closed. 57% said their flesh had been removed from their genital area. 2% said that their genital area was cut, but they did not have flesh removed. And 12% did not know the type of FGMC they had experienced. We did find that more women who had experienced FGMC reported health concerns, specific health concerns compared to women who had not experienced FGMC. So for example, we asked about problems with childbirth, which could include postpartum bleeding, extensive vaginal tears from childbirth, or emergency C-sections. We found that 67% of women who had experienced FGMC reported a problem with childbirth, compared with 49% of women who had not experienced FGMC. We asked about reproductive health problems that could include difficulty passing period blood, difficulty passing urine, pain with urination, or UTIs or urinary tract infections. 47% of women who had experienced FGMC reported having experienced one of these problems, compared with 23% of women without FGMC. We also asked about sexual health problems that could include pain or bleeding during sex. We found that 44% of women reported a sexual health 44% of women with FGMC reported a sexual health problem, compared with 17% of women without FGMC. And finally, we also asked about reported feeling sad for many weeks at a time to try to get a sense or a proxy for mental health. And we found that 35% of women with FGMC reported this feeling, compared with 24% of women without FGMC. We wanted to assess the extent to which women felt comfortable talking to their provider about their FGMC experience. We found that over half of women, or 58%, reported that they would feel comfortable discussing their FGMC with a healthcare provider. However, only about a third noted that they had discussed their FGMC with a healthcare provider. We also wanted to assess FGMC beliefs of all women surveyed, not just those who had experienced FGMC. So we found that the majority, or most women, believe that FGMC should be stopped. 87% believe that FGMC can cause health problems later in life, and 82% do not believe that FGMC is required by their religion. So we just wanted to talk through some strengths and limitations of the study and what the study does tell us and what it doesn't. Some of the strengths is that it includes women from multiple countries of origin, immigrant generations, and length of time in the United States, which, as I noted earlier on, existing research tends to focus on a specific region or a specific country of origin. So having this purview across multiple countries of origin and region is a strength. We also had a standardized questionnaire, so that allowed us to compare findings across the different areas and questions. However, some limitations about this study is that we cannot generalize these findings to an entire US population. This doesn't necessarily produce prevalence of affected or at-risk women and girls, just because this is a multi-site study focused on 4 areas rather than a national study. The study relied on women's self-reported knowledge of their actual FGMC status, so there was no clinical confirmation or provider assessment that noted whether FGMC had taken place or not. So it depended on women's self-reporting and their willingness to do so and disclose their FGMC status. We also restricted to women age 18 plus. And so, we did not ask about or document anything related to vacation cutting or taking girls to a different country in order to have FGMC conducted. And finally, I just like to thank and acknowledge all of the people who made this study possible, which there were very many of them. We have our NORC staff, we have our WHNS implementing partners, all of the community partners across our 4 regions that helped implement this study, and as I noted, helped design and collect data. All of the participants, the over 1,000 women that were part of this study, our community partners, as well as our advisory group of national subject matter experts, and of course, our funders. So this study was conducted with funding from the CDC Division of Reproductive Health, the CDC being the Centers for Disease Control and Prevention. We also had funding from the Department of Health and Human Services Office on Women's Health, and Department of Justice, National Institute for Justice Office for Victims of Crime. So we have to thank all of our partners who made this work possible. I'm going to skip this slide for a second just to also note that there are various areas where you can find more information about this study. NORC has its a webpage on the Women's Health Needs Study that is available. The CDC also has a page on the Women's Health Needs Study that is available. And as part of our webpage, we do have an infographic available that has all of these findings and data that I just talked through today. I also just wanted to acknowledge our contact information if you have any additional questions beyond this webinar, both for Caitlin and myself. I'm the project director of our project we're on, whose email address is listed on this slide. So I'm going to pause and turn it over to Caitlin to talk a little bit more before we turn it over to Q&A and questions. Thank you.
Thank you so much, Petri. I appreciate you sharing these findings. I think they're very interesting, and I really appreciate you sharing them. I want to share a little bit from my perspective at the U.S. network, and what this data can provide for both the US network as well as some of our members. So having this data that you just shared, really to document the experiences of FGMC survivors, particularly with their experiences around accessing health services, is incredibly valuable both for the US network and our members. We have some members, some of which are on this webinar right now, who are doing some really great work training healthcare providers on FGMC. And to be able to provide this data to show how survivors are experiencing medical services is important in improving these experiences, and ensuring that any gaps that are in place are filled. I was particularly interested in seeing that 31% have discussed their FGMC with a healthcare provider. Even though more said that they were actually comfortable, I'm really curious about why there's that gap there. And I would also be curious to hear from medical providers their thoughts about that, right? Do they think that folks are coming to them with this experience? Because the data is showing that only 31% is, and how can we change that? It's also really helpful to see how survivors' experiences overlap with other areas, and to have the data to demonstrate these intersections. So specifically, I'm thinking about the findings that you shared around survivors' access to interpretation. That for me was discouraging. I think we would ideally love to see 100% of folks who would like interpretation or translation services were offered it and received it. And so how can we find ways and programs to change this and to again educate health providers around this, as well as these intersections with access to reproductive health, and some other areas that you had mentioned. And lastly, I just want to share, and then we'll get into the Q&A. But seeing survivors' perspectives on FGMC is also incredibly valuable, particularly seeing that 91% believe that FGMC should be stopped, and 82% do not believe that FGMC is required by their religion. As I'm sure you all know, in the US, we still very much see FGMC being considered a religious practice. And so hearing survivors specifically say that they don't believe that's the case, I think is really valuable, particularly when we think about advocating for policies, right? And laws, to ensure that these survivors' voices are centered in the policies and laws that we create here in the US. So thank you again. I very much appreciate you sharing these findings. We do have a number of questions that have come in, so I will go through those with you. And for the participants here, please feel free to keep adding questions. We do have plenty of time for the Q&A. So if you can think of any others, please feel free to add them to the Q&A at the bottom of your Zoom screen. So the first question that I want to ask you, Petri, is, are your findings based only on African countries? And if you can just share a little bit more about the rationale for how you selected the participants and the eligibility for the study.
Yeah, absolutely. So yeah, we do know and acknowledge that FGMC happens across the world beyond African countries as well. Our study was specifically limited to African countries, and this was based on the selection of those countries was based on an analysis we did of available data in terms of prevalence of FGMC in specific country, in the kind of those specific countries of origin. And I don't have the exact number off the top of my head of what our cutoff was for percentage, but we only selected those countries that were above that cutoff. And so that is where our list of countries came from, which was entirely from countries in Africa. But we do know that this practice does exist beyond that.
Great, thank you. And I'm not sure if you have an answer to this question, but I'll ask you anyway, just in case. But Laura asked, in the countries that showed a lower rate of experiencing FGMC, does the study offer any legislative or cultural trends over the years that affected the lowering rates of FGMC?
Yeah, that's a great question. We don't currently. So it's a cross-sectional study. So it's kind of a one point in time within that study period that we had between November 2020 and June 2021. So we don't have trends across years of increases or reductions. And also, these are about the experiences of women who are currently in the U.S. based from these countries that are from Africa primarily, though we did not look into specific kind of legislative practices or things that were contributing. We were mainly trying to assess the experiences of women in the U.S. at this time.
Thank you. And that, I think that's a great question, because that's certainly, important to think about, right? Particularly when we talk about prevention, is understanding when there has been success and when prevalence rates are going down, why is that? What is the reason for that? Katie asked, did you find that FGMC beliefs differed among women who reported experiencing FGMC and those who reported not experiencing it?
Yeah, that's a good question. So we're actually still in the process of doing some analysis and hopefully having additional information out that will kind of cut across some of these other variables as well. So I think I don't have an answer for you on that at the moment, but we're hoping that future findings can talk more about some additional stratification of these variables across the other variables that we had, including things like FGMC versus not for attitudes, beliefs, etc.
Great, thank you. And to our participants, we're getting through the questions very quickly. So if you do have any others, please feel free to add them to the Q&A. We do have some time to continue answering your questions. So please type any questions that you have in the Q&A. Petri, Bettina asked if you can say something about the percent cut by generation, so the 1, 1.5, and 2 or second generation.
Sure, that's not a data point I have available at this time. Again, we're in the process of doing additional analysis. So at this moment, we just have age at FGMC, which we noted where when people reported that they experienced their FGMC, and we know their immigration generation and know that the majority of women are kind of first generation and immigrated after age 13. So we can kind of make some assumptions there, but I don't have that data point yet. And hopefully future iterations of findings can provide some of that information. But thank you for the question, Bettina.
Laura asked, and Petri, again, I don't know if you have the answer, but I have an answer to this question, so I'm happy to answer it. But Laura asked if anyone knows of any city governments that have made FGMC a priority. And I can share about the US specifically, because that's our focus. I know New York City has set up a coalition around FGMC that is run out of the mayor's office. And so that is really great to see, particularly such a large city in the United States. Outside of that, not really. Most of the work around FGMC and with governments is on the state and federal level, and we don't see a lot of city level action around FGMC. But Petri, I don't know if you have anything to add to that question.
No, I think that covers it. But I do want to acknowledge, I know that from an earlier question on what our cutoff for prevalence of FGMC in the country of origin for our selection of countries, 65%. So thank you, Chris, for that.
Great. And last question that we have is from Dorisa, who said, great study and thank you for sharing the results. But Teresa asked, what's next for the study and or around sharing the results?
Absolutely, and that's a great question, and also just a segue and a plug for our webinar next week, which is, as I noted, we have this infographic of findings, but we are continuing to do additional analysis, and hopefully we'll have other reports or manuscripts to share later on as well with additional findings. But more importantly, we are spending time with our community partners that participated in the study, and we are in the process of starting to disseminate some of these findings, particularly from the infographics. So we're working with our community partners, and you'll hear from Amani Women's Center and Sauti Yetu next week about their activities and what they're working on. But the intent is that they're using these findings to help inform their programs and services, to communicate the data back to the women who participated in the study, or just the community more broadly. That will be doing trainings at both national and local levels for providers, and providers in the broader sense of the word, not just healthcare providers, but also those that provide social services and others to immigrant and refugee populations, cultural sensitivity trainings, and those kinds of things. So we're hoping that all of these data can inform those dissemination efforts, both at the community level, but also at a national level, as well as we think about continuing to disseminate these findings.
Great, thank you. And for folks on this webinar that are members of the US network, we continue to work very closely with NORC, and as some of the findings are published, we are happy to help share it with you all as well. We did have another question come in from Michelle. At this time, are there any plans to include the perspectives of men on FGMC in future iterations of the study? We know that men have a lot of power in society and have influence around the practice of FGMC. So curious if you have any insight around that.
Absolutely. So there are currently, so far this has been a one-time study, but we're hoping that this study does open the door for kind of future studies, future conversations, future funding around ways that we can continue to learn more about the experiences, including some of the questions you all asked today, including experiences of men, et cetera. So hopefully, as we continue to disseminate and findings and continue to have more conversations with you all and with partners and with funders, that there will be additional opportunities for expanding findings from this study to other questions, or repeating the study, or other kinds of things. So we're definitely interested and open and welcome ideas if you all have them as well.
Great, thank you so much, Petri. It looks like that is all the questions, so we are finishing ahead of schedule. But I do want to thank you once again for sharing these findings. I know I myself have really been looking forward to it, and I know many of our members have been looking forward to hearing about some of these findings as well. So I appreciate you and the rest of the team at NORC for taking this time to help share some of the findings. As you mentioned, we do have part 2 of this webinar next week on June 15th at 1 p.m. Maddie has included the registration link. So if you have not yet registered for part 2, you can find the link in the chat. We would love to see you there. And as we mentioned, part 2 does include some of the community partners who will be sharing about their involvement in the study, as well as how these findings impact the work that they're doing on the ground with FGMC survivors. So I'm definitely looking forward to that conversation. So thank you once again. Thank you all who participated. And this recording, or this webinar, has been recorded, and we will be sharing out the recording with you all as well. But thank you again. Thank you, Petri, the team at NORC, and thank you everyone who participated today.